Hello everyone, my name is Juliana Padilla and today I will be presenting my case study on pericarditis. Patient presentation. A 35-year-old woman who is otherwise healthy has had constant retrosternal chest pain for 2 days. The pain worsens when she lies down and improves when she sits up and leans forward. On physical examination, the patient is afebrile and has a friction rub. The 12-lead electrocardiogram shows widespread ST segment elevation without Q waves and concomitant PR segment depression. The etiology of pericarditis is idiopathic, 85 to 90% of cases, mostly related to viral infection as well as bacterial infection. I did list other factors of pericarditis, however, they are not as significant. Background of pericarditis. About 5% of people with non-ischemic chest pains are diagnosed with pericarditis. 20 to 30% of patients with acute pericarditis will have recurring symptoms. If the pain persists continuously for over 3 months, the condition is considered chronic, which may lead to fluid around your heart, called pericardial effusion, and may even lead to tamponade, rapid fluid accumulation, a very serious condition. Constrictive pericarditis or restrictive pericarditis, also chronic, may also occur. Like tamponade, compression of the heart happens as well as eventually reducing cardiac output. Unlike tamponade, constrictive pericarditis develops gradually. Purulent pericarditis is associated with a mortality rate nearing 100% for untreated people and a mortality rate of 12 to 40% for treated patients. The mortality rate in constrictive pericarditis approaches 50%. Who is at risk of developing pericarditis? Both men and women are affected. Individuals with viral infections, trauma, systemic inflammatory diseases such as rheumatoid arthritis, MS, and lupus. Certain medications, however, this is rare. Complications from myocardial infarction, and high levels of urea in the blood. The normal pericardium. The pericardial sac is made up of an inner mesothelial layer, which covers the heart, and lines an outer fibrous layer onto which the mesothelium reflects. It produces up to 50 milliliters of fluid, which serves to lubricate the motion of the heart, and overall serves to prevent excess cardiac motion. Pathophysiology. Pericardial disease results from inflammation of the pericardium, which in turn can give rise to an effusion, and rigidity of the pericardium giving rise to the constriction syndrome. In figure A, you can see a normal pericardium with two layers of pericardium. In between those two layers, you have a cavity filled with fluid. In figure B, you have a heart with pericarditis. You can see the two layers of pericardium inflamed and rubbing against each other. You can also notice no fluid in between the pericardial cavity. The cause of pain in pericarditis. The visceral pericardium is innervated by branches of the systemic trunk, which carry afferent pain fibers in a cardiac distribution, and the vagus nerve, which may trigger vagally mediated reflexes in acute pericarditis. In contrast, the parietal and fibrous pericardium are innervated by somatosensory branches of the phrenic nerve, which can give rise to referred pain to the shoulder. Symptoms of pericarditis include chest pain, worsens when lying down or when breathing, and improves when sitting up or leaning forward. Palpitations may suggest underlying myocarditis. Syncope or presyncope may suggest effusion or myocardial involvement. Pleuritic symptoms may suggest connective tissue disease or periodic fever syndrome. Fever may point towards bacterial infection. The diagnostic test of choice for pericarditis is echocardiogram. An echocardiogram shows how well the heart is working, as well as detecting pericardial effusions, constrictive pericarditis, and stiffness and thickening of the pericardium. Other diagnoses include chest pain characteristics of pericarditis, pericardial friction rub, a scratching, grating sound caused by the roughened pericardial membranes rubbing against each other, hypotension, and electrocardiographic changes. This image shows the echocardiographic examination of a 60-year-old woman with acute pericarditis. The purple dashed lines reveal echo-free space, suggestive of moderate pericardial effusion. Treatment for patients with acute pericarditis consists of relieving symptoms and includes administration of anti-inflammatory drugs. In pericardial effusion, aspiration of the excess fluid through pericardiocentesis may be needed. Initial treatment for constrictive pericarditis consists of restricting dietary sodium intake and administration of diuretics to improve cardiac output. These are my references. Thank you for listening.